trained in surgery, is a general surgeon, but specialized early on in surgical endoscopy, in laparoscopy, and in matters of gastroenterology that are of interest to surgeons, including nutrition. And he has the unusual distinction of having been president of both surgical and gastroenterology societies in South Africa. He has taught endoscopy and surgery, laparoscopy around the continent of Africa, and has huge experience, has a huge legacy in terms of people that he has trained and influenced. And he's talking to us today about documenting endoscopic procedures and findings. And I think he's going to talk to us about how documentation can lead into databases and into research. So Dr. Thompson, it's a real delight for us to have you presenting to us today. Thank you.
Thanks very much, Mark, and thanks to all of you. I hope you can hear me all right. Please give me some feedback if the volume isn't as you would like it. And so, yeah, as you see, I've been sort of working in South Africa for quite a long time. And really, I'm a sort of surgical gastroenterologist come endoscopist who's very interested in training and trying to help develop endoscopy training and the practice of endoscopy in Sub-Saharan Africa, and because that's where I am and where I have some sort of knowledge over the years. So I'm going to sort of now share my screen and move into my talk, and I'm quite happy, to take questions at the end. I think that's the format for your meeting, so I'm happy to do that. So I'm going to share my screen. So what I'm up to is sort of going to talk to you about is improving endoscopy reporting, practicalities and benefits. And I'm a surgeon, so I like to try and keep it simple if I possibly can. What do we currently do? I'll show you some data from South Africa. And that really illustrates why we don't do it very well. I'll talk about some of the WA standards for reporting, which Lars Beacon, who's in the audience, was responsible for putting forward. I'll talk about data entry at source in the endoscopy room, because I don't really believe in secondary data entry. And that's obviously a logistic issue. And then the idea that endoscopy reporting can be used both for management and research is key to the whole thing. We should all be interested in how we can improve our own clinical approach in medicine, and how we can use our endoscopy resources to their best possible utility. So this is some an article that was reported from New Zealand in their journal, and you can see exactly what we showed. Again, most of you are using a typed or dictated endoscopy report, and usually that's a freehand. It is very much orientated towards what you find in an individual. It doesn't generally carry a lot more information than what you actually find. So there's no negative reporting of things that you don't find. And again, there are a whole lot of endoscopy programs developed for recording. And again, in large hospitals, certainly in high income countries, these are often integrated into the hospital record and the hospital reporting system. We'll speak a little bit more about that. And in some places, for instance, in Johannesburg, they have both a medical and a surgical gastroenterology unit, and they report on their procedures using different forms, which obviously doesn't really make much sense. So even in reasonably sophisticated setups, things are not what they appear, or they certainly, I think, in my opinion, could be better. So this is one of my other tasks, is to edit the South African Journal of Surgery. And this was an article that was prompted by the primary author and the senior author, who's a colleague of mine, because they were appalled at the status of their freehand reporting. And this is how they report. They use a standard format for all their endoscopies. They're only doing upper and lowers. And they devised a scoring system for each of these areas to see how well the data was recorded. And this is the table from it. And I won't go into the details of that table, but I'm sure many of you are used to a type of form like this, which is often used for a freehand written report. And they graded them as grade A, grade B, and grade C. And grade A was satisfactory, and they had no gastrointestinal reports that met those. And in fact, 84 were grade C, which is really not something that you can use for research, and even for clinical management, it's very, very unsatisfactory. And again, they noticed that illegibility was a problem. Obviously, with typed reports, that's not such an issue. And then, of course, common classification systems were not routinely used. And in upper endoscopy, that would be esophagitis classification, Barrett's, and again, also characteristics such as site and the actual description of the ulcer. So handwritten reports are going on, and I'm sure they are going on in Africa, and they aren't very good, and they don't uniformly collect data. This is a document, again, it's a document that was drawn up by the WEO, and takes a lot of time to sort of get consensus on what information you should be recording. And I would advise you to have a look at this report. I'm not sure, maybe Lars can tell us if it's been updated subsequently. But the essential thing is that it looks at anatomical structures, endoscopic findings, reasons for endoscopy. So that's the indication for endoscopy, the actual endoscopic diagnosis. So they do want to record a diagnosis, procedures, actually what you carried out and how you carried it out, and whether you had any peri-procedural adverse events. Of course, there are other things that you can record, comorbidities, whether patients are taking drugs that might be relevant to endoscopic procedures, such as anticoagulation. Obviously, allergies are an important issue if you're dealing with patients who you're giving drugs to. And again, there are other issues such as procedure timing, trainee assessment, procedure comfort, and KPAs, which in many high-income countries are routinely being recorded as part of the system to get the best out of their endoscopy system and to get the best out of it for your trainees. This is just one of the pages of the 45 pages. And again, you can see this is about luminal findings and how you can use a term, how you can describe it as with an attribute, and then the actual attributes that you would use to define that attribute. So again, those are basic formats of how you should be thinking about reporting. And I would commend you to read this document when you can get a chance to. So what are endoscopy databases? They are computer-based medical records that are used to document clinical activities. They're designed primarily in most settings to support clinical care by recording the endoscopic findings, storing images, and generating reports. Many of them, especially when you're not working in a large GI unit, suffer from poor accessibility for research and limited ability to extract or export data. And a structured and comprehensive electronic endoscopic database can potentially be used for research and quality improvement in clinical care. Not just research as to find out things about pathology, but also how you run and handle the service for your patients. And again, it translates into improvements in clinical care if you use it well. What are the current available systems? Well, you can have one in your endoscopy room that's linked either to the stack or it's a separate computer within your endoscopy area or the room you perform it in. Again, it can be integrated into your hospital informatics system as part of your e-record. But basically, you want them to collect relevant data on all patients that are endoscoped. How can you do that? Well, you can use mandatory fields. That's a very good way of ensuring that you get good quality data. Some individuals find that a very frustrating experience when they start working with databases. Again, you can record key performance indicators. You can look at competency assessment. And one of the other things that you can do, which I will get to in a minute, is image capture and recording of interesting cases and maybe even routinely recording, depending on what you are. And the idea really is that you should be able to integrate this into the patient's overall hospital record. Again, many patients have multiple pathologies and they need to be taken into consideration when you're managing the patient, including GI. So what are we going to collect? I've already sort of gone through that. Relevant data on all patients that are endoscoped. This is I'm just going to take you through a couple of examples. This is the Olympus example. Actually, none of the other major manufacturers have got systems that they specifically market, but Olympus do. And again, this is their sort of interface. It's quite easy to use. Again, it has a booking system that you can see. Again, these menus take a little bit of getting used to and can be assessed for how good they are. And again, it allows you to capture the images real time from the endoscopy procedure. And the beauty about these systems are that they do link the taking of still images to the buttons on the scope. Again, that's maybe quite problematic with custom devised systems. Again, you can see here, there's a sort of comprehensive array, but none of them are mandatory, and they all are essentially very much in the free text. Olympus do have a format where it can be integrated into hospital informatics systems. These are generally extremely costly, and certainly for general purposes, it's a very expensive tool for what you get for the money. This is interestingly from your sister college in Addis, your opposition, so to speak. So I'm sure that you work together for patient care. And this is a system that they devised. Again, it has a computer interface. It's nice by its simplicity. And again, it generates for the various sites. Again, it indicates what is the indication and anesthesia. So it doesn't detail exactly what's used. And again, it generates a report that can be pushed out and utilized. Again, you can see exactly how it would integrate with the hospital's system itself. And then there are a few things that I've been involved with because I've actually designed one of these for my own endoscopy unit here in Cape Town quite a few years back. And again, you can try and make them user-friendly and easy to fill in by having pull-down menus, operating guides, interfaces that are easy and naturally flow. We generate a PDF report that can be emailed. We don't have a booking system integrated into our database. We do have assessment modules. We don't have equipment maintenance, and my hospital doesn't bill for endoscopy procedures as an itemized system. Again, I spent some time and tried to roll out this endoscopy system that I developed in Kenya, in Sudan, and in fact, I think it's installed on your system, though, just for trial purposes when I was with you when Lars was there a few years ago. Well, not so many years ago, just before COVID broke.
Yeah.
Which was a very interesting trip. So this is what our system looks like. And again, you certainly can't enter any patients unless all the mandatory fields are filled in. And we designed it so that it was idiot proof, that all the red had to be gone before you could proceed to the next screen. So that's how it simply works. And again, as I say, it generates a report for all our endoscopy procedures with slightly different data sets. The other thing is that your data should be exportable. And if you're going to use some sort of database, you want to know how can it export the data. And usually Excel is the simplest mechanism to export it. And it can be, from Excel, it can be imported into almost any other software and combined quite easily. And I would commend anybody who's doing this to make sure, if you're installing one of these systems, that it has an exportable data set. And Excel is far and away the easiest one to deal with, that most people are familiar with. I want to just talk a little bit about key performance indicators. And I just use colonoscopy for this, and these are actually the UK ones. And again, you can see that there are many things that are now being routinely recorded. For adenoma detection rate, you should read polyp detection rate. Polyp detection rate is a surrogate for ADR. Obviously, we don't have access to the pathology report at the time we take the polyp off or biopsy it. And you can see that bowel preparation, withdrawal time, cecal intubation, they're all interrelated. And again, your volume of colonoscopies is another issue that you want to be able to do. And you want to be able to generate this sort of information for your trainees so that you can see how they're progressing during their training. There are some other things here that are involved in the UK system. But again, this key area in the middle that is interrelated are what we're looking at. And to do that well, you do need to capture images. And you can see. And so you can see here that this is also one way of documenting how good your colon preparation is for diagnosing, especially screening. It can't be poor or inadequate. Otherwise, you will miss lesions and you will miss actual cancers or advanced adenomas. And what are the key performance indicators? Well, here's the ileocecal valve and here's the appendix. And again, those would be considered key performance indicators for colonoscopy. I just want to talk now about, obviously, I think it's important that you do document these with photo documentation. Then obviously you can have some quality control rather than thinking you've arrived or that your nurse thinks you've arrived at your destination. Of course, you can document photo documentation. I alluded to that. You can do it with fancy cameras. You can do it with now the more modern endoscopes have got USB outputs. Again, that involves removing the output at the end of each case if you're going to enter it into a data set that isn't integrated into your hospital system. You can always use a phone, and in fact, in our unit, we often use a phone. We do have capture using USB sticks, but they're not quite as instant as having it on your phone. And on your phone, you can share it with people much easier in the hospital. So a lot of my trainees have been using the phone as well, fortunately, as using the USB capture device. However, these are not direct, and we have recently updated the system so that we can do direct capture from it. And I'll take you through that because I think these are very applicable ways of capturing images that can be done in resource poor environments or not such rich environments as we have in Western Europe and America. Basically, you need the endoscope. You have a capture device to capture the video. You have a computer. You have video capture software. You record the video, and you can use a shortcut key or foot switch to capture the image. And I'll just take you through that because for me, that's been a little bit of a journey. And I quite like fiddling around with computers and images. So I've spent a bit of time trying to do this. You need to know what's happening at the back of the stack as well as happening at the front of the stack. And this is the key to successful video capture. It's the DVI output. And you can take that either from the monitor or from the back of the processor itself. And for those of you who are not familiar with how videos are captured, these are the ones that have really made it much easier to capture these. And I'm not sure if any of you are gamers, but the gamers know how to capture and stream live video better than most people. And so if you want to find out about how to do it, visit some of their websites. And by and large, now most modern endoscopes have DVI out, and you can convert that to HDMI in, which is very easy to capture. You may have on some of your endoscopes S-video, and S-video is another way that you can import video quite easily into your computer. Then you need an adapter. These are very cheap from Amazon or Take-A-Lot in South Africa, and you need an S-video cable if that's what you've got on your endoscopy system. Or you can buy a video capture device. When I first started this, I used to get them from Alibaba Express. COVID meant that takes about 4 months now, but in those days it would come to you in 2 weeks, about a quarter of the price that I would pay for it in South Africa, and it was very difficult to access. And obviously you need an HDMI cable, a DVI cable, and then obviously some device to connect the capture device to your computer. You can buy a computer that will do the job for, in our country, 5,000 Rand or $370. It can be a laptop. It can be a little box that people use for home entertainment systems, or it can be a computer, as you can see on the right. And again, this is the sort of specs that you need. It may sound to be high end, but that sort of specs are now reasonably easily attainable with fairly inexpensive computers. So again, I don't know what these cost in other African environments. What you also need is some free software. This is what the gamers use. It's called Open Broadcast Software, and you can load it for whichever system you've got. And I would really recommend that if you take, I believe this is recorded, but this website down here is the best YouTube on how to use Open Broadcast Software. And essentially that's how you're going to record the images and capture it. You obviously have to open that. So you've got the capture software. You then connect your instrument, as I've showed you here, with an HDMI cable from DVI. And the other thing that I'd be interested to hear what you do in your environment, but one of the things is that almost all the endoscopy stacks have the ability to record some basic demographic information. And certainly in our place, nobody uses it to do that. And in actual fact, it's really the best way you can of being sure that you identify any images or videos that you take from the patient. So I'd commend you to start at least putting the patient's serial number in the into this system, which is usually has its own keyboard, because then when you capture things, it will carry that symbol with it, because it will capture the actual screen. So this may be a quantum shift in some endoscopy units, I can assure you, because it does involve double data entry. And then you start up your open broadcast software, load in your capture device, and you will see the image from your monitor. All you have to do is start recording. And it will record the whole of the procedure. It will also allow you to time it, because it actually times your procedure, which is a key performance indicator. Again, you can decide how you want to store the videos. They do take up a lot of room, but obviously you can wipe them because you're using them as a vehicle to be able to take a static picture. And the way to do that is to put your image to full screen, and then you can use a device that will be a shortcut key, either on a keyboard, you can use a print screen, or you can connect it to a USB foot pedal, which is what we've just got in the unit now, to make life a bit simpler. So it's pretty easy to do. You have a few connections to make. You have to look at the logistics of connecting these things up in your own environment. But I would commend you that it is eminently feasible to do that. And what we do is that those images are automatically recorded onto the computer hard drive, and we just grab them into the database and drop them in the database at the time that we do the report. And it's really quite a simple process. It's actually exactly the same way as Olympus do it, except they integrate it into the software in their database. So what can I say? I'm sure you've had enough of me rabbiting on about things that I'm quite passionate about. But current data recording is inaccurate and inconsistent. And if you're relying on typed reports, they are very difficult to get consistent information to do anything regarding planning your endoscopy service or research. There are lots of recording systems, and they are not difficult to devise, even if they have to be self-developed. You want to take note of what you want to record, develop your minimum data set. And again, if you're training people, you do want to monitor how they're doing it. And the database allows you to do that. And it allows you systems that are capable of image and video capture. I think photo documentation now is feasible, and I do believe that it should be mandatory if you're doing endoscopy procedures, as it's one of your main quality control tools. We do need data for Africa, and I would suggest you need to consider how you might want to implement some of these things that I've been talking about in your own environment. I'm happy to try and help if people wish to do that. I've done a lot of Zooming since COVID, and it's a very good platform to try and help people. And we've been setting up a telementoring setup to Namibia to be able to telementor individuals through ERCP in Namibia. So, and they're based on some of the same principles that we've been using here for video capture. So thank you for that. Thanks for listening to me, and I'm happy to take any questions you have or may have.
Thank you, Sandy. That was fantastic overview with both the theory and some excellent practical demonstration. So there's a number of questions here and I'll start just to read them out. And if you have questions or comments, please enter them in the chat box, and we'll go there. So there's a number of questions here, Sandy, asking, is it possible to have a reporting system that could work across an entire country or indeed the entire continent of Africa? And what's your take on that?
Well, I think one of the things that has come into being. I know the WGO is working on a system to do these sort of things, but I do believe that you want to set up systems that are standalone in most hospitals, that have the ability to be integrated. So what I believe is that you should have a PDF output that can go into the general informatics system, so that they have a record of for clinical management purposes. And I do think that if you're trying to do something in Africa, what you want to do is to try and decide on a minimum data set that you want. That may be research driven, but I think you can make it for clinical purposes as well. For instance, in the colon, you want to know how many polyps, would be one of the minimum data sets. And then I think if you're going to do any integration, it must be anonymized. I think there's a lot of thing about personal protection of data, and that's a really key issue all around. And when you do that and you export it, you can anonymize it when you export it. So I think being able to do it within your environment and being able to have a system that can export it anonymized is the way to do African research, to find out that, and to try and get WEO centers and WGO centers to try and define a minimum data set for the 3 or 4 common endoscopy procedures, but I would say mainly for uppers and colonoscopies. And that would be the way I would envisage it. Then you stay away from privacy issues and hosting things on the internet, and who's responsible for that safety of that data, shall we say, in terms of personal protection. We're going through a whole new, we call it the POPI Act here. It's all about personal protection, and to be honest, it's a pain in the backside. It's going to be a pain in the backside when it's implemented.
Lars,
so I'm sure. Yeah.
Lars has his hand up. Lars, you want to comment on this?
Yeah, because I think Sandy is exactly right about setting up standalone systems. It sounds like a great idea to have like one joint system feeding into some internet storage somewhere, having the same system for all. I think that's at the present time is an illusion, mainly because the privacy issues are difficult to deal with, and also because the internet connectivity is unstable and variable. And I think basing a system on that would, at this point, be very difficult. So I think I would much rather see standalone system, maybe several, but with some standards in the bottom, and then a export mechanism, if anything, about a standardized minimal set of parameters, which could go anonymized into some common repository at some point. But I think that's a much more viable model for data collection.
Talk to us, perhaps both of you, but you first, Sandy, about, well, first of all, there's a question here, a follow-up on what we've already discussed. For clarification, if you have standalone systems, you can have that data transferred to a central system, right? And I think you've implied that, but there was that follow-up question. Sandy, you want to comment?
So what we've done is we originally hosted our database on a university server, because my hospital is a university server, and it has a hospital network. The two are actually separate, which is again to do with this privacy issues. But it's much more integratable into the hospital record if you have it on the hospital system. So again, this business of having a standalone system that produces an output that can be fed into the hospital system, I think is a good idea. So our output's a PDF. So the hospital, the oncology can access our colonoscopy report on a cancer without having to come and see us or wonder where it is in the notes, because it's available as a PDF on the system. So that's one way of doing it without having the actual database. It's being hosted on their server, but it isn't integrated into their system. It just produces an output into their system. It's one way around it. Again, that's exactly what I think you should do.
Now, there's a number of questions about cost and setting things up. And I can imagine there's several related issues. Like some of us might say, you know, I'm ready to take on the computerized report generation, but the whole image and video capture, you're right, it's important, but we just can't sort of take that piece of it right now. So Sandy, talk about how can different endoscopy units in Africa actually implement this? What's the cost? Can it be done incrementally? And what are some really practical options to get started?
But Mark, can't Haile Mikkel mention a little bit about the system we set up in Addis? Because that would be like a zero cost option. And I would like Haile to at least mention that.
Yes, I agree with you, but let's start off with Sandy and see what he has to say.
Okay.
Well, I mean, most of the software programs that you can do it with, Lars has developed a reporting system. I'm not sure how it captures images into it, but again, if the reporting, if you save your images to the computer that you're doing the reporting on, they're importable into the report, and they're importable into a permanent data set. If you've got the room to if you have the hard drive space to do it. So I think that's really fantastic. Again, you know, you can use, there are a variety of software programs that you can use. Some people have an interest in it. Usually there's somebody in your faculty who's interested in data capture. They may be a cardiologist or someone else. But I think the cost of doing these things is really quite small. As I said, the computer is 5,000 Rand. I don't know if that's out of the reach of the hospital, but it's usually not out of reach of the doctor. So some of the stuff I've done is, you know, I've provided the data from very minimal funds. Then an HDMI cable is about $10. A DVI to HDMI cable is no more. So the connections are cheap. The capture cards, again, they come in various shapes and sizes, and but they're no more than 200 or 300 Rand, or $20 to $60, depending on what you buy. So they're not. I don't think they're not zero cost, but they're minimal cost. And I believe also that the computer must be in the endoscopy area. Ideally beside the endoscope. So you do need a dedicated computer. And again, if you can link it to the hospital system, then you may be able to send your reports out in a variety of different ways, either by email, which is another way you can do it, or to individuals' phones on WhatsApp and other devices. Again, the youngsters are generally more au fait with this type of thing. And I'm sure there must be a few gamers in your audience here. They're the people who really know how to stream things and to record things, and to do it for, you know, minimal cost. So I think you can do it with costs that even in the African setup are realistic. Again, it depends on the outputs of your endoscope, but most of them, the old ones will have S-video, and most of the new ones will have DVI.
So let's go back to the actual software that creates the database and generates the report. Your system that you showed, what's the cost of that? If, you know, we wanted to install that in a hospital one of us works in, what would we pay for the software? What's the licensing fees, et cetera?
All right. So I currently have a free license for the software. I can give it to anybody who wants to use it, and I can give them the program. So there's
Wow.
no cost for that. Yes. But if you want to update, it is in a commercial program. It works on the version that I've got. And obviously, if you go to a commercial program, then you'd have costs to buy that program. I think it's on a program called FileMaker.
And you have generated some significant research from these procedural databases that have been created. Is that right? I mean, you haven't talked about it today, but I've heard you speak about some of this elsewhere. So I'm asking you just to fill the audience in on what can be done.
So we took our data on colonoscopy and we've analyzed it from a variety of different angles, but the main one that we've analyzed it from is our adenoma detection rate. Adenoma detection rate in Africa, or polyp detection rate, whichever you want to do, but we did adenoma detection rate. We merged the histology database with our database. So all the patients who had polyps, and we recorded on the polyps the number, the size, whether they're sessile or pedunculated. We didn't do Paris, and we didn't do any NBI on it, but we just amalgamated the polyps and the histology. And we found that the rate in our African population is 5%. In our Caucasian and colored population, it's between 15 and 20%. So adenoma detection rate is key. I think the Addis, your other Addis hospital, also did some work and presented it at the WGO meeting. I'm not familiar with it, but this is the first data set from a public hospital that I know in Africa. And the other problem in Africa is that the volumes generally are very low. In Zimbabwe, they take about 6 years to do the same number of colonoscopies that we do in a year. And we do about a third of what they do in a district general hospital in UK. So the actual volumes are small, relatively speaking, as far as I'm aware, in many African countries. I think Nigeria is also very similar. There's no real large volume centers producing a lot of colonoscopy data. Their volume of colonoscopies is quite low, probably even too low to train well, to be honest, from what's published at any rate.
So Haile Mikhail, can you mention, as Lars brought up, how you've implemented a reporting system and database in your setting, and what the lessons are you might have for others?
Yeah, I think, thank you, Professor Thompson. This is really a practical presentation. You have shown us not only the technical aspect, also how we can really do it practically, establishing a video capture system with the scopes that we have. So as you have been saying, it's really a local system. And if you can really share us a software program to this Sub-Saharan Africa EcoSpokes, that will also be a great support for us, I think. So at St. Paul's, we have been using what has been created by Thompson and also from Professor Lars. So we have been using this, and through time we have seen that when they found that the one which has been developed by Professor Lars Abakan, you have been there, they found it an easy way, and most of the residents or the fellows and the faculties were using that system. So simplification is one thing I think that people need. If you can use these two type of softwares, and we can come up into some standards and integrating these two softwares, that will be, I think, one important thing that we can use. It's a simplified software system which can be installed in any camera easily. And what we lack is, what I can see from this, what I can also get from this topic is integrating also into the hospital system is a plus, standardization of some important pointers, not only in the written pointers, but also in the pictures. And it's possible, it will be very important if we integrate it to the pathology, to the oncology unit. That is something that we lack also here. After that, we send them a printed out copy to the pathology. And Professor Mark, you have also seen that sometimes we didn't get the pathology reports. So integrating it into the pathology, oncology, and sending it into one system, into hospital system, will be something that we lack. But after we use the software that we have in the computer system, with a low cost, we are having a better standard system. I think if you allow, we can share that to the ECOS folks.
Yeah, I think if you've got a system that's working and it's acceptable to your staff, you should try and develop that system and see what its scope and limitations is. I know Lars has based it on a Word document that's exportable into Excel. And again, I think the essence is that however you generate it, whatever software you use, and some of the software is really, available for nothing. You should use that and develop it with a minimum data set. That's what you should do. And then you must decide how in your own environment, because we're not practicing in your hospital.
Yes.
We are practicing in our own environment, and we have our own limitations. And again, also some people who are very helpful and some people who are positively obstructive. Some IT people are not as helpful as they can be, because they're a bit too worried about this privacy thing. Forgive me, but yeah. So yes, I think it's good. Just now, do you currently have a video capture system? Are you using anything to capture your images? Highly.
So
can you do it? I'm asking. Are you doing it? Rather than can you do it?
I have here Robin, who is trying to use different S-video systems. With we have the different video capture systems that you have shown us. We have it here now, and we are trying to utilize it. We have done it at some time, but it was not uniformly used. And Robin cannot. So we have an IT person here also who is helping us.
So as you said before, Professor, because moving everything directly to the IT might be difficult sometimes. People in medicine are moving to IT as well, so joining those stuff. So I'm one of them. But this is an interesting concept we would like to try. But the video capturing, we tried it with OBS Studio as well as just directly getting the video with an S-video cable. We don't have HDMI capture card yet, but we tried that and it works perfectly. And we can record it, we can save it as well, but we haven't integrated into the already established software yet. So I think we can work on that.
That's fantastic.
So I'd like, in a few minutes that are left, I'd like to ask Lars to comment on the minimum standard terminology and how to implement this in an endoscopy reporting system. 45 pages is a lot, Lars. So if we had to go through 45 screens to enter data for every report, I think there'd be a rebellion. And I was also interested to see in the example that Sandy gave that descriptive terms weren't used. It was the endoscopist's impression, benign or malignant stricture, not any descriptive term about what it looks like. And, I always thought the report should just describe, and then in the impression, you might have your judgment about what it is. But Lars, help us with these issues. And how can we use minimum terminology without taking an hour to generate a report?
The whole idea of the MST was to have a separation between descriptive features and then an interpretation at the end. So I think the specific example of benign versus malignant stricture was a little bit of an anomaly. It's not the normal model for the MST principles, I would say. But I don't think you need to worry about the 45 pages, because I think it's all about how the software is able to present that. Now, the idea of the MST is partially to give you a sort of a structure of how things should be described and what words should be used to describe them. And so in this latest publication, which was from the World Congress in 20-something in Shanghai, it's about the terms, it's about the report structure, and it's about image documentation, because those are all standardizable components of how you report your procedures. So the documents describing the terms are all available free of charge on the WHO website, so you can just go there and download them. And the idea would be that anyone who's setting up a reporting system at least should have a look at that. And it's not, you know, I mean, one size doesn't fit all, and you would need adaptations, but just starting from that, you know, framework will make systems look more alike and standardize to some extent the language that we're using. Now
have you found that many of these systems are now incorporating the MST language, or you find it's still an uphill battle and a lot of systems are using other approaches?
I don't think it's like universally utilized, but I can say that I mean, we're using the Endobase from Olympus, and we have a, you know, 100% implementation in that. So for that software, at least, it was very easy because I set that up and I used the MST exactly the way we were, you know, thinking that it would be used for anyone setting up a database. So I mean, the software developers would create a structure and the logic, but to populate that with the right terms and the right, you know, structure, that would be for the endoscopists and ourselves to input, I think.
You're muted, Mark.
Sorry, thank you. I think we're coming to the end of our session, and I want to thank especially Dr. Thompson for sharing his experience and his insights in this area and how we could make progress. And for everyone on the call, I would point out we have some real international experts here who, if you want to be setting up a database in your hospital or you want to be moving into image capture, I think, you know, we'd be happy to connect you with Dr. Thompson, with Dr. Abakan. You've heard from Haile Mikhail about a system, a Lars design that's in use in St. Paul's Hospital. There's some chat comments from Dr. Sultan, Amir Sultan, about the system at Black Lion Hospital that Sandy showed. And I think all these folks would be happy to give you a hand. So feel free to reach out. We've also seen some notes from here from Akwi and others about combining data to try and answer questions that any one place in Sub-Saharan Africa couldn't. And I think that's a beautiful idea, but setting up one of these systems in your hospital is like step one towards that, it seems to me. So a lot of fruitful grounds for further progress here. Haile Mikhail, any final words?
Yeah, I think this was really quite fruitful, especially if you also add, if you have any pointers, we can share this with Sandy Thompson and Professor Lars Abakan, and we can share with the softwares, and then we can have, at least as Professor Topazian said, a standard protocol in our unit, and then this can be extrapolated to African. As when they present, I was considering that the studies that we have seen, if they are not set to the standard, the publications, it's difficult to extrapolate also from those publications if they don't have if they don't meet also the standard. So having a standard set of documentation is, I think, a prerequisite and the most important thing that we can take from this conference.
So I'll conclude by mentioning there's a feedback link in the chat.
Yeah.
Just a few comments up from the bottom. Please take just a moment to log on there and give us some feedback so we can keep improving.
Yeah.
And we'll look forward to seeing many of you in a couple of weeks.
Yeah, sorry for interruption. So next talk will be given by Professor Lars Abakan after 2 weeks on non-variceal upper GI bleeding. So join us for another exciting talk next 2 weeks. And as I've been also reminding, please share us also your cases. And if you want to present a patient case, we always need you to send us cases to be presented in this eco session. Thank you all, especially Professor Sam Thompson, for today's.
Absolutely.
Pleasure.
Thanks, Sandy.
Thanks very much. Enjoy. Bye-bye.
Thanks so much. Professor Mark is in. He's in. Dr. Abdu is asking for Professor Mark.
Where are you, Mark?
Abdu, hi, I'm in Rochester, Minnesota at the moment.
Oh, that's good. I thought you are here. Somewhere.
No, we're visiting our home for here for 6 weeks,
Okay.
seeing our family, friends, working a little bit here, which is a lot of fun. So
Please say hi to all of them.
how are you, Abdu?
I'm fine. I'm fine. I was having the body face last week,
Oh,
so it was good.
okay.
Unfortunately, you can't attend to my defense.
I walked by your clinic last week. I was amazed at the number of patients waiting. You have a very busy service.
Me too. I was also busy with hospital evaluation in focus. But on the top of that, I defended my research well. And, that was good.
And have you been
Telegram mail.
have you defended your thesis yet?
Yeah. I did last Wednesday.
How did it go?
It was fine.
Good.
So see you then.
Ali Mikhail, what is our plan about July and August? I forget.
Yeah, still, many of the spokes need us to be here. So we'll remain here and we'll have sessions. So
Okay, so we will have sessions all the way through.
yes, we'll have sessions all the way through. So I'll send you an email on that.
Okay.
Yeah, we have sessions, the next sessions, at least we have 3 sessions set. Type C.
Yes, we do.
Numbers.
We'll fill in some of the schedule for August.
Yes.
Okay.
Yeah. So we have for Luis hasn't yet decided topic.
No, it would be good to get one from him.
Yes.
So,
yeah.
okay.
That's good. So we need to ask Luis as early as possible.
Yes, I'll do that.
Yeah, he's really busy now. We have another talk on. He has another talk on HCC, another session. So
Perhaps he can use some one of these things for our clinic also.
HCC, Professor Luis. Probably after a month and 2 weeks. 1 month and 2 weeks back. So he's a pathologist. So we can ask him his area of interest actually, because he has been involved in the basic evolution of HCC and also in the treatment, epidemiology of HCC, molecular genetics, oncology. So Abdu will also supplement on like HCC, colorectal cancer management when you have presentations.
That would be great.
Yes, that would be really great. Yeah. especially involving the cases to be presented, because the feedback link from ECHO always asks us about patient case. Have you presented a case? It asks us. The feedback link started with have you presented a case? Yeah, it always stimulates case presentation.
Yeah, we have a lot of patients,
Yeah,
HCC patients, so we can present one of them at the start of the session.
yeah,
That would be great.
Yeah, and the oncology perspective as well,
yeah.
as we did last time.
Esophageal.
Yeah, esophageal.
Hello, Simran.
Hi everyone,
Hi.
how are you?
How are you?
I'm well.
Yeah.
So I really like the fact that today everything was followed, like pre-presentation, everything. But actually, me and Riddhi would like to discuss few points with everyone. So can you let us know your availability for the same? Maybe in the coming Thursday or Friday or next week, whenever it suits you.
Thursday or Friday would be difficult for me this week. Next Tuesday, June 15 would be possible.
Okay. And time slots, like
Although I have another call at our usual time.
so.
I could do an hour earlier if Haile Mikhail was agreeable to that.
Yeah. For me, yeah, okay. So, like Ethiopian time around 3 p.m. on Tuesday, 3 p.m. you'll be okay. Yeah. Robert? Yeah?
It would be okay for me as well.
Okay.
Sure. So next Tuesday, an hour earlier of the
Yes.
session, right?
Yes. Yes.
Okay.
No, we
I'll
have-
check with
we have
Riddhi
a
if it's
session
possible for her, and then I'll share the invites.
That is for the time. Yeah.
Sure.
Yeah. Sure. Any other pointers? So there are people who can say hi or bye. We are closing the session. Sami, can you hear us? Can you? Sami Budabos. Stephen McHenry. Jerry, how are you, Jerry? You have been here. Okay, I think they are muted. Professor Mark, have a
I
good
did. Same to you. Greetings to your family, Haile Mikhail.
Yeah, please greetings to your family too.
Good
And
day.
the weather looks bright today. Yeah,
Yes, but it's too hot and humid here. It's much nicer in Addis.
Okay. Yeah.
So I think after the too humid weather, you would enjoy the weather in Addis more. So
Absolutely.
it's a good
Absolutely.
experience.
Yeah.
So I remembered my assignment, but I haven't sent you the actual measurement. I will do that as soon as possible, Professor.
So Robel, in addition to an S-video cable, I'll get one of these DVI to HDMI cables, and I'll look for a long Ethernet cable. But if there's anything else we're going to need, let me know. We have the new towers there.
Yeah.
So also, if you could check the HDMI capture card that has been shown earlier from Amazon. I think it's cheaper on Amazon. So the HDMI capture card will allow us to stream the videos not only using S-video but also using other cables like the HDMI, the VGA cable. So I think it will let us use other ports we haven't been using.
So is that different than the one Dr. Abikin provided for Haile Mikhail that
Yeah.
attaches to his computer?
Yeah, it is a different one. The one only uses the ACE video cable, but the HDMI capture card is a box which have an HDMI input and output on both
Multiple.
sides.
Yeah.
So it's kind of different. Maybe I would send you the link. I think I would take-
Robel, if you can send me a link to an Amazon page
Yeah,
with the thing you think was what is needed, that'd be very helpful to me.
that would be good.
Send it by email.
Sure, sure.
Someone also saying that's Amazon or
Yeah, from Amazon.
yeah, from the chat box. Someone also saying that's how to buy all that.
So this is the small
This is a
one.
mini USB.
I'm looking here. I didn't see it. Oh yeah, he has his HDMI capture box there.
Yeah, yeah. Capture card, audio video capture. I think this
It's all-
really is.
It's all in French.
It has
this particular
HDMI cable.
one.
Hmm.
Oh no, there we go. I can change it.
Yeah.
And that looks like it's not available in the US. That's a European one, but yeah, I mean, it's
Yeah,
it's the same idea.
Available.
Currently,
That has only HDMI inputs and outputs. I think Robel might want something with additional inputs and outputs, but I don't know.
Yeah, but HDMI outputs will be enough to. We can connect the HDMI output with the VGA. We could connect it with other type of output. So
But would you like a box that has other inputs such as S-video, composite?
yeah, I haven't came across a box that have multiple inputs that I also include S-video, but I will check that. I only got boxes that have HDMI to USB or HDMI to HDMI input and output. So I will check on that because
Even a USB output or a place to put to a memory stick might be useful. I don't know.
yeah. That's the HDMI box. The box might have
Either Mikhail, the box you have has an HDMI output, doesn't it? It takes in other signals and it outputs HDMI. Is that true?
no, it's not HDMI.
It's just
S video and USB cable.
S-video to USB.
Hmm.
But what does it output to the computer though?
So through the USB cable.
Just USB.
Yes. So as we are alone, Prof,
Yeah.
I just want to, I put some of them in the waiting room. I was considering if we like on the list we have AQE, so give the next one.
Yeah.
And okay.
We have Abdu on our list for other
Abdu?
malignancies.
Yes.
Um,
Purnima Path. You know Purnima?
yeah, sure.
Yeah. So Purnima has also shown interest. And Dua Kulwinder on esophageal stricture, fistula, leak, RCP, and EUS.
Yeah, that's a good idea.
Yeah. Dr. Abdu, you have him for non-surgical management of HCC.
Abdu, are you more interested in talking about HCC or colorectal cancer or both?
Yeah, I can.
Yeah. When we need patient case, some different fellow can come and present patient case and put us questions. How can we treat? And then like some questions.
Okay, so we
Some-
will present the case.
Yeah.
And give you the
Yeah, you give the lecture.
and,
Yeah, Professor, I've also sent you a link to an HDMI capture box, which is a different one. It was suggested in the chat by Sam. And what it does is it allows multiple inputs and also captures directly into a memory stick without the need for PC. I'm not sure how to manage it right now because it's quite new for me, but I will check it out, how to capture using the box. So this will be another option besides the HDMI capture card.
Okay, well, I'll thank you, Robel, and I will follow your lead on what the best thing to get will be.
I will also check out and update you through emails as well. So it was nice seeing you, Professor.
Great to see you, Robel.
Yeah, I hope all families are well and they're safe. You're enjoying the time.
Thank you so much. Thank you. Yeah, and I hope you're doing well too, and look forward to seeing you in person again in August.
Same here. Thank you.
Okay, see you later.
All right, we'll see you
Already
all.
missed you, Prof.
Well, looking forward to seeing you soon.
Yeah, have a lovely time there. Yeah. Patient case